All right. Good afternoon to you all. On behalf of India Alliance and India COVID SOS, I would like to extend a very warm welcome to this panel discussion on enhancing vaccine equity in India. My name is Supriya Kumar, and I work with India COVID SOS, an international nonprofit organization of volunteer scientists working alongside communities on the ground to build, share, and deploy evidence-based solutions in response to COVID-19. We are pleased to partner with India Alliance today to co-host this discussion. So before I go any further, I want to thank Nicolette Jadhav, the communications lead at India Alliance, and her team for their help in organizing this panel, all their work behind the scenes, and the India Alliance CEO, Dr. Vasan Sambanamurthy, for his interest in hosting this panel discussion. So this will be an action-oriented panel discussion in which we have requested the panelists to all present their specific initiatives and approaches to improving vaccine equity in India. It isn't the first time that we're talking about vaccines or vaccine uptake, but ensuring equity in uptake remains extremely important and of great interest in India. Panel members today come from government, civil society organizations, and the public health research establishment, and have been advocating for vaccine access amongst women, Adivasi populations, and other socially disadvantaged communities. They will present their experience of how community engagement and effective risk communication can result in greater equity in vaccine uptake. I'd encourage you, the audience, to discuss proactive approaches to ensuring vaccine equity in the Q&A and to amplify the voices and strategies of our panelists in your own communities after this discussion. So we'd asked members of the central government for their thoughts on vaccine equity and have received a 2-minute video recording from the Joint Secretary, Ministry of Health and Family Welfare, Mr. Lav Agarwal, which we will play now.
Let me thank organizers for organizing this important discussion today. With respect to vaccination, India had actually followed a research-driven, science-driven, and epidemiologically based approach towards vaccination. We launched our vaccination drive as early as 16th of January at the level of Honorable Prime Minister, and we ensured that the major manufacturing capacity which exists in India, the research capabilities which exist in India, they are put to the maximum use, they are hand-holded, they are escorted in terms of not only ensuring that the vaccines which are developed even in other parts of the world are majorly produced in India, but also that we are able to have a vaccine indigenously researched and produced in India. So far, India has already given emergency use authorization to 5 vaccines, and we have done more than 450 million vaccine doses across the country. Not only the program has been expanded by hand-holding manufacturers in terms of increasing production, the effort has also been to create effectively just-in-time logistics management approach so as to ensure that whatever vaccines get produced, they reach to the community immediately. Parallelly, we also work from an epidemiological perspective in terms of identifying the priority sectors in terms of healthcare workers and frontline workers, as well as also the fact the priority age groups where the mortality could be high for prioritizing for vaccine doses, etc. What I would like to highlight, our whole process is work on the approach of using technology in a manner where we can ensure that the people are given vaccine doses, they are monitored for adverse events, they are also monitored and supported and guided in terms of ensuring when the second dose of vaccination is due. From our perspective, India's perspective, the battle to COVID is still ongoing, and as part of our strategy, 5-fold approaches in terms of test, track, treat, COVID appropriate behavior is now supported by vaccination as a major tool. Thank you.
Okay, so many thanks to the Joint Secretary for providing those comments. So let's move on to the panel now. It will be moderated by Gunjan Sharma. Gunjan has been a health and science journalist for 17 years. She covered health for about a decade for The Week and was the founding editor of healthpost.in. Gunjan has won numerous awards for her journalism, including the Mumbai Press Club Red Ink Award in 2016, the German Development Media Award in 2013, and the International Press Institute Award in 2011. A biotechnology graduate, she has been a guest lecturer at various journalism schools and a speaker on public health at conferences and seminars across the country. She is currently working with UNICEF as an independent communications consultant, helping the government of India in COVID-19 communications. So once again, welcome to you all, and I'll turn it over to you, Gunjan.
Thank you, Supriya. Indeed, as Mr. Lavagar also highlighted, equitable access to COVID-19 vaccine is vital to contain the pandemic that has so far killed over 4 million people and damaged economies, pushing millions into poverty. As WHO says, effective vaccines can take years to develop and even longer to ensure that they reach all who needed them. But it certainly could not be the case during the pandemic. Before we begin this session, I would like to show you a video from Chamarajanagar district in South Karnataka, which is home to 40,000 Adivasis. The video shows how the community responded to the government's vaccination attempt. Could we have the video, please?
ನನ್ನ ಹೆಸರು ದಾಸೇಗೌಡ, ನಾನಿರೋದು ಭೂತಣಿಪೋಡು.
ನನ್ನ ಹೆಸರು ಸಿ ಕೋಣೂರೇಗೌಡ ಅಂತೇಳಿ, ನಾವು ಈ ಕನ್ನೇರ ಕಾಲೋನಿಯಲ್ಲಿ ವಾಸ ಮಾಡ್ತಿರೋದು.
ನನ್ನ ಹೆಸರು ಈರಮ್ಮ, ನನ್ನ ಊರು ಮಾವತೂರು.
ಸಣ್ಣಗೌಡರು ಅವನ ಮೊರೆ ನಾವು.
ನನ್ನ ಹೆಸರು ಮಾದಮ್ಮ, ನಮ್ಮ ಊರು ಜೀರೆಗದೆ.
ನನ್ನ ಹೆಸರು ಸೀತೇಗೌಡ ಅಂತ, ನಮ್ಮದು ಊರು ಹೊಸಕೋಡು.
ನನ್ನ ಹೆಸರು ಮಹಾದೇವಮ್ಮ, ಎರ್ಕಿನ ಗದ್ದೆ ಪೂಡು.
ಮುತ್ತಮ್ಮ. ನನ್ನ ಹೆಸರು ಜಯಮ್ಮ ಅಂತ.
ನನ್ನ ಹೆಸರು ಸಿ ಮಹಾದೇವ್.
ನನ್ನ ಹೆಸರು ಬೇದೇಗೌಡ.
ನಮ್ಮ ಹೆಸರು ರಂಗಮ್ಮ ಅಂತ.
ನನ್ನ ಹೆಸರು ಪುಷ್ಪ.
ನನ್ನ ಹೆಸರು ಶೇಖರ್.
ನನ್ನ ಹೆಸರು ಡಾಕ್ಟರ್ ಸಿ ಮಹಾದೇಗೌಡ ಅಂತ ಹೇಳಿ, ನಾನು ಬಂಗ್ಲೆಪೋಡು. ನಾನು ಕೋವಿಡ್ ಲಸಿಕೆಯನ್ನ ಪಡೆದಿರ್ತೇನೆ.
ಆದ್ರೆ ನಮ್ಮ ಕುಟುಂಬದಲ್ಲಿ ನಾವು 4 ಜನನು ವ್ಯಾಕ್ಸಿನ್ ಹಾಕ್ಸ್ಕೊಂಡಿದ್ದೀವಿ.
ನಾನು ಆಶಾ ಕಾರ್ಯಕರ್ತೆ, ನಾನು ವ್ಯಾಕ್ಸಿನ್ ಮಾಡಿಸ್ಕೊಂಡಿದ್ದೀನಿ.
19 ಏಜ್ ಆಗಿದೆ, ನಾನು ಇವತ್ತೇ ವ್ಯಾಕ್ಸಿನ್ ಹಾಕ್ಸ್ಕೊಂಡಿದ್ದೀನಿ. ನಾನು ಚೆನ್ನಾಗೇ ಇದ್ದೀನಿ.
ಕೊರೋನಾ ಲಸಿಕೆಯನ್ನ ನಾನು ಹಾಕ್ಸ್ಕೊಂಡಿದ್ದೀನಿ. ನನ್ನ ಮನಸ್ಥಾನ ಚೆನ್ನಾಗಿದೆ.
ನನಗೆ ಮೊದಲೆಲ್ಲ ತುಂಬಾ ಭಯ ಇತ್ತು, ಇವಾಗ ಏನು ಹಾಕ್ಸ್ಕೋಬೇಕಂತ ಒಂದು ಧೈರ್ಯ ಬಂತು, ಹಾಕ್ಸ್ಕೊಂಡಿದ್ದೀನಿ. ನನಗೆ ಏನು ಜ್ವರ ಗಿರ ಏನು ಬಂದಿಲ್ಲ.
ನಾನು ಹೋಗಿ ಇಂಜೆಕ್ಷನ್ ಮಾಡಿಸ್ಕೊಂಡು ಬಂದಿಗೆ 3 ತಿಂಗಳಾಯ್ತು. ನಾನು 20 ವಯಸ್ಸಾಗಿಯೇ ನಾನೇ ಧೈರ್ಯವಾಗಿರುವಾಗ ಊರ್ನವರೆಲ್ಲ ಕಾಡ್ ನುಗ್ತಿದ್ರು.
ನಮಗೆ ಇಂಜೆಕ್ಷನ್ ಮಾಡವ್ರೆ, ಇವೆಲ್ಲ ತೊಂದ್ರೆ ಬೇಡ.
ನಾನು ಕೊರೋನಾ ಸೂಜಿ ಹಾಕ್ಸ್ಕೊಂಡಿದ್ದೀನಿ, ನಾನು ಚೆನ್ನಾಗಿದ್ದೀನಿ. ಬೇರೆಯವರು ಸುಳ್ಳು ಮಾಹಿತಿನ ಹೇಳಿದ್ದಾರೆ, ಅದು ಸರಿಯಲ್ಲ.
ಹೋಗಿ PG ಪಡೆ ಸೂಜಿ ಹಾಕ್ಸ್ಕೊ ಬಂದೀನಿ, ಏನೂ ಆಗಲಿಲ್ಲ ನಮಗೆ.
2 ಸೂಜಿಗಳನ್ನ ನಾನು ತಗೊಂಡ ನಂತರ ನಾನು ಆರೋಗ್ಯವಾಗಿದ್ದೀನಿ, ಚೆನ್ನಾಗಿದ್ದೀನಿ. ಯಾಕಂದ್ರೆ ವಿಜ್ಞಾನಿಗಳು ಅಷ್ಟೊಂದು ಸಂಶೋಧನೆ ಮಾಡಿನೇ ಬಿಟ್ಟಿದ್ದಾರೆ. ದಯವಿಟ್ಟು ಈ ಚುಚ್ಚುಮದ್ದಲ್ಲಿ ಯಾವುದೇ ರೀತಿಯ ತೊಂದರೆಗಳು ಇಲ್ಲ.
ನಾನು ಕೋವಿಡ್ ಲಸಿಕೆಯನ್ನ ಪಡೆದುಕೊಂಡಿದ್ದೀನಿ, ಯಾವುದೇ ತರಹದ ಅಡ್ಡ ಪರಿಣಾಮ ಇಲ್ಲ.
ನಿಮ್ ಸೂಜಿ ಹಾಕ್ಸ್ಕೊಂಡು ಇರ್ತಿದ್ದಾರೆ, ಅನ್ನಗೆ ಸತ್ತೋಯ್ತಿದ್ದಾರೆ, ಹಾಕ್ಸ್ಕೋಬೇಡ ಅಂತ. ಈಗ ಸ್ವಲ್ಪ ಜನ ಭಯ ಕೊಡ್ತಾರೆ ನಮಗೆ. ನಾನು ಹೋಗಿ ಇಂಜೆಕ್ಷನ್ ಮಾಡಿಸ್ಕೊ ಬಂದು 2 ತಿಂಗಾಯ್ತು. ಇನ್ನೊಂದು 15 ದಿನ ತುಂಬುದ ಅಂದ್ರೆ ಹೋಗಿ ಇನ್ನೊಂದು ಇಂಜೆಕ್ಷನ್ ಮಾಡಿಸ್ಕೊ ಬರ್ಬೇಕು.
ಈ ಕಾಯಿಲೆ ಒಬ್ಬರಿಂದ ಒಬ್ಬರಿಗೆ ಹರಡುತ್ತದೆ, ಭಯ ಪಡಬೇಡಿ, ಎಚ್ಚರಿಕೆಯಾಗಿರಿ.
18 ವಯಸ್ಸಿನ ಮೇಲ್ಪಟ್ಟ ಎಲ್ಲ ಯುವಕ ಯುವತಿಯರು ಕೋವಿಡ್ ವ್ಯಾಕ್ಸಿನ್ ಅನ್ನು ಪಡೆದುಕೊಳ್ಳಿ, ಹೊರಗಿನ ವಿಚಾರಕ್ಕೆ ತಲೆಗೊಡಬೇಡಿ.
ದಯವಿಟ್ಟು ಎಲ್ಲ ಸಣ್ಣಗಟ್ಟಿಯಾಗಿ ಇಂಜೆಕ್ಷನ್ ಮಾಡಕ್ ಬರ್ತಾರೆ, ತಕೊಳ್ಳಿ ಅಂತ ಬಂದ್ರೆ ನಾನು ಹೇಳವ್ನಿ.
ಸುಳ್ಳು ಸುದ್ದಿನ ನಂಬೇಡಿ, ವ್ಯಾಕ್ಸಿನ್ ಹಾಕ್ಸ್ಕೊಳ್ಳಿ.
ಅದನ್ನು ದಯಮಾಡಿ ನಮ್ಮ ಎಲ್ಲ ಆದಿವಾಸಿ ಸಮುದಾಯದವರು ಲಸಿಕೆಯನ್ನು ಪಡೆದುಕೊಳ್ಳಬೇಕಂತೇಳಿ ತಮ್ಮಲ್ಲಿ ವಿನಂತಿಸಿಕೊಳ್ತೇನೆ.
ಈಗ ನೀವು ಅದನ್ನ ಹಾಕ್ಸ್ಕೊಂಡು ಮತ್ತೆ ನೀವು ಚೆನ್ನಾಗಿರಿ.
ನಮ್ಮ ಕಡೆ ನೀವು ತಕೊಳ್ಳಿ ಸೂಜಿನ.
ನೀವು ಕೂಡ ಲಸಿಕೆ ಹಾಕ್ಸ್ಕೊಂಡ್ರೆ ಮುಂದಕ್ಕೆ ಚೆನ್ನಾಗಿರ್ಬೋದು.
ಸೋಲುಗರಿಗೂ ಕೊರೋನಾ ಬರಬಹುದು, ಅದರಿಂದ ಕೊರೋನಾ ಸೂಜಿನ ಹಾಕ್ಸ್ಕೊಳ್ಳಿ.
Yeah, so the video is a proof that when there are right interventions, people respond. India began its COVID-19 vaccination drive on January 16, 2021, with 2 vaccines which were given emergency authorization, Bharat Biotech's Covaxin and Serum Institute's Covishield. In order to protect the most vulnerable, India, like any other country, first made it available for the healthcare workers and other frontline workers who are most exposed to the infection. Then elderly and people with comorbidities who are more susceptible to catching severe disease and mortality before opening it up for all adults. Though there are some inspirational stories from across the country, ensuring that everyone gets the jab, irrespective of their gender, socioeconomic status, and location, is not a simple task. And today, we will discuss with our eminent panelists the various challenges the country faces to ensure all those eligible to get the jab. Dear audience, may I please request you to kindly keep your video and microphone in a switched off mode. You can leave questions for speakers anytime during the webinar in the question box below. In case the webinar ends abruptly due to a technical glitch, join back using the same registration link. Now, I would take pleasure to invite my first panelist, Dr. Gagandeep Kang, a noted vaccine scientist. Dr. Kang is a professor of microbiology at the Wellcome Trust Research Laboratory, Division of Gastrointestinal Science at Christian Medical College in Vellore. She has worked on the development and use of vaccines for rotavirus, cholera, and typhoid, conducting large-scale studies to define burden, test vaccines, and measure their impact. She is the first Indian woman to be elected a Fellow of the Royal Society. She serves or has served on the Scientific Advisory or Strategic Committee of several national and international institutions, including the Wellcome Trust UK, the DBT Wellcome Trust India Alliance, the International Vaccine Institute, and the International Centers for Genetic Engineering and Biotechnology. She is a member of several advisory committees for the WHO, mainly related to research and use of vaccines. Welcome to the panel, Dr. Kang.
Thank you very much for the introduction, Gunjan. And, I think the idea of vaccine equity and ensuring access for all of our population is something that is really close to all our hearts, or we wouldn't be here. Now, the question really is, this is our first adult immunization program. We've never done this before. We probably, hopefully, will never need to do something like this again. But if we look at our entire adult population, that is effectively about 950 million people needing to receive most likely 2 doses of vaccine. So we are talking about 2 billion doses of vaccine needing to be available and needing to reach those 950 million people. If you look at our routine immunization program, which is something that we are familiar with, that we are very proud of, that is a program that is aimed at children. We have an annual birth cohort of about 27 million children. And to them, we give vaccines at multiple touch points, 5 touch points during the first year of life, and then a couple after that. Now, when it comes to looking at how this program has performed, it was established in the 1970s and has built up over time. We now give 12 vaccines to our children, and our coverage is 90%. So this is a group where we know that, we've been trying to push for maternal births to happen in facilities. So we have access, we know when children are born, and we know when to reach those children because we've built interventions around maternal and child care. But we still reach only 90% of our children, which means that India actually has the largest number of unvaccinated children in the world. Now, if we haven't been able to do that for our children with decades of investment, what is it that we need to be doing differently in order for us to be able to ensure equitable access to new vaccines for our entire population at a time when supply is a limitation. So of the 2 billion doses that we need, we are currently vaccinating at about 150 million a month, which means that there is a long way to go. You highlighted the prioritization, and that prioritization was developed based on principles of ethics and science that were established by the World Health Organization. And the first principle was reciprocity. If people in the healthcare system are responsible for looking after people who are sick with COVID, they are also putting themselves in the front line to ensure that people can be looked after, then they have to be prioritized. And then comes the prioritization that is based on burden, where we know that age and comorbidities are the determinants of severe disease. So when we think from a scientific and a policy perspective, the policy that was described by Love Agarwal, the policy that has been put in place in India, is based on science. But the problem really comes when it comes to implementation. And what is it that we can do in terms of implementation to make sure that people don't fall between the cracks as happens in the routine immunization program. So the way the scientific community can approach this, one is obviously to make more vaccines. And in India, we have 2 vaccines being made and approved for restricted use, 1 imported vaccine currently also being manufactured in the country, and multiple vaccines in development, including the world's first DNA vaccine, which is under consideration for review. So if we want to enhance equity, we need to make sure that there is more vaccine available and more vaccine that can be tailored to specific priority groups. For example, people who cannot receive a certain kind of vaccine should have a choice. And then from the science community as well, I think the video was an excellent example of how the Institute of Public Health has looked at education of communities and countering vaccine hesitancy. But vaccine hesitancy is also a very local problem that needs local solutions that are driven both by science and by culture. So making sure that when there are particular myths or miscommunication or disinformation being spread in the community, we have a responsibility to ensure that we don't live in our ivory towers, that we get out there, that we communicate to people why some beliefs are false. For example, saying that women will be infertile if they take the vaccine. Well, that is based on pseudoscientific principles of cross-reactivity between proteins in the placenta and proteins in the coronavirus. That's a very easily countered myth, but it really requires for scientists to be science communicators as well. And some of us don't invest as much time and effort in it as we should. The other thing that I will point out from both a science and a system perspective is the need to think about tailoring situations to the data that we see coming in from the ground. So distribution, for example, when you learn that the COVID app is allowing for urban residents to book appointments in rural areas, what is it that you can do to be able to make sure that vaccines go where they are intended to go and the right people get the vaccines? So there is a lot that from both a science and a policy perspective that we can do, but it does need for all of us to recognize that there is an issue, measure it, and work together. Back to you, Gunjan.
Thank you, Dr. Kang. You very rightly said that I think, all these aspects, be it proactive public communication by scientific community, more vaccines in our basket, ramping up our production capacity, prioritizing groups, addressing hesitancy, and a revamped distribution plan can ensure equitable access to vaccines for the entire eligible population. Thank you so much, ma'am. Moving on to our next panelist, Ms. Uma Mahadevan. Uma Mahadevan is 1992 batch IS officer of Karnataka cadre, who is currently serving as the Principal Secretary Panchayati Raj in Rural Development and Panchayat Raj Department, Government of Karnataka. She holds a postgraduate degree in English literature and has authored multiple articles and publications covering socioculture and art discourses. She has served in multiple capacities at the center and state, including as Principal Secretary in the Department of Agriculture, Education, Health and Family Welfare, Women and Child Development. She has also served in the Department of Atomic Energy, Government of India, and Tata Institute of Fundamental Research. She was an active member of the working group who charted the Human Development Report. She guides the 3-tier Panchayati Raj institution in the overall development of rural areas in Karnataka state. As a civil servant, she is known for her passion for inclusive change. Thank you, ma'am, for accepting our invitation. I would like to know, what do you think is the best approach or strategy as far as convincing people in rural areas about the importance of vaccines, and also the role of panchayats and local administrations? How can they work towards making vaccines available to the population?
And thank you to India Alliance and Wellcome Trust for organizing this discussion and for having me on this panel. It's a great pleasure to be here. I have got a few slides which I wanted to show. Let me just see if I can start showing my screen. If there's someone at that end who can, I had shared my slides. If somebody from that end can share it, it would probably be easier because I'm finding it a bit hard to figure it out.
Yes. Yes. Can we please have ma'am's Miss?
Is the screen showing?
Yes, it's visible.
Yes, it's visible. You're able to see it. Okay. So the thing I wanted to start with, and this can just let me just figure out. Okay. So are the slides moving or?
Can we have the next slide, please?
Can we have the next slide, please? Yeah, I'm not able to figure out. So maybe I'll stop sharing the screen. Okay. All right, I can see it. So these are glimpses from rural Karnataka. What I'd like to talk about is before vaccination itself, what we did in Karnataka is we took a holistic and integrated approach in rural Karnataka. In March 2020 itself, when the pandemic was declared and when we knew that in rural Karnataka we'd have to take steps, we set up, we have 6,000 local governments. So what we did was to set up 6,000 Gram Panchayat task forces. These task forces include the elected representatives, the Panchayat staff, as well as the Asha workers and Anganwadi workers. So these task forces became a platform for convergent action, and I'll explain how in a minute. You can see this is a typical Panchayat task force meeting where we have elected representatives, we have the staff, we have Asha workers, we have Anganwadi workers, as well as representatives of other departments working on the ground. The Panchayat task forces at this time, this was in March 2020 when the lockdown had been declared, and people in Karnataka were celebrating the Ugadi festival, for which they had, a large number of people had gone to their villages, and it became imperative to communicate as quickly as possible. So what we did was to set up these task forces, and immediately from the next day itself, take up, since in-person training was not possible, we took up YouTube live training for the task forces on effective science-based communication about the coronavirus, about precautions to be taken. And here's another task force meeting about precautions to be taken and about masks, physical distancing, and the ways in which the economy, the local everyday life of the rural people, including the milk cooperatives, the water purification plants, the going to the fair price shop and so on, could be carried out without significant danger or risk of infection. So this was one of the things that we started right at the beginning. And what we found was the Gram Panchayat task forces thereafter became a platform not only for communication, because the information that we gave, which was science-based, was thereafter transformed by them into, converted by them into local media, including wall art, rangolis on the ground, and they have a traditional method of drum beating. It's called the dangura. And so there is a traditional way of making announcements in the village where a drum will be beaten and a person will go from street to street making the announcements. So this information, we feel, being backed by science, managed to plug what could have potentially been a source of misinformation and a spread for stigmatizing, for panic, for misinformation, and so on. And this also helped the Gram Panchayat to gain the confidence of the rural public at a time when, during the lockdown, other technical departments and other staff of other departments could not easily make their way to the rural areas. Therefore, it became a natural thing to transition from communication to effective COVID management by testing, taking up rapid antigen testing, as well as swab collection for RT-PCR tests, by tracing primary contacts, secondary contacts, by isolating those with travel history. So Gram Panchayats in Karnataka managed effectively as many as 11,000 institutional quarantine centers. They managed tracked home quarantine cases in the first wave, and then again in the second wave, they managed even the COVID care centers. This is the kind of training that we gave on YouTube Live. This is an example of the training that's going on. And house-to-house visits by the Gram Panchayat to communicate the need for masks, for precautions, for understanding the prevalence of NCDs, for understanding whether people had any non-COVID emergencies for which they needed help. This, I should say, was a tremendous asset for us, because we have something like 94,000 elected representatives, 80,000 staff, another added to that, another 40,000 Ashas and 60,000 Anganwadi workers. These were a very effective force for communication in rural areas at the front lines of the pandemic. This is an example of the COVID care centers run by the Gram Panchayats in the recent second wave. And this is a picture I'm very fond of, because here is the care with which people were accommodated in the centers for 10 days with good food, hygienic arrangements for beds and so on. And this actually is where patients after 10 days are being discharged with flowers and given a kind of an affectionate send-off from the COVID care center. All of this goes to say that the Gram Panchayat task forces have already gained the trust as local representatives and local task forces. They've gained the trust of the rural public, and therefore from here to move to the activity of vaccination, to communicate to people, educate them about the importance of vaccination, and enlist the eligible for vaccination was not a difficult thing. Here is an example of the wall writing. This is a panchayat in Dakshin Kannada district, where panchayats have taken a lot of effort to communicate in different formats, to identify the eligible persons, inform them about the benefits and the need for vaccination, conduct communication campaigns. We created material in different languages, in different media, print, audiovisual, and so on, even jingles and folk songs, and in different formats. As you can see, wall writing, there were huge Rangoli campaigns and so on. registration, sorry. So here's a registration desk and a help desk, which helped in every panchayat to clear some of the doubts and fears that people had, and also to help those who were not digitally literate to enroll with their documents for the vaccination. So we use what I would call the 3 E's, to educate, to enroll, and to ensure that all the eligible people are covered. We also helped through the panchayats. This is a group of senior citizens who were helped by the panchayat with transportation, with enrollment, with documentation, and brought back, and also helped with effective education about the need to follow COVID appropriate behavior even after the first dose of vaccination. This is an example of a vaccination happening at a MGNREGA work site. This is in the panchayat where persons with disabilities are being vaccinated in the open air. This is an example of a panchayat member getting her vaccination, because panchayat members came forward to get vaccinated before the others in order to reduce vaccine hesitancy and to model good behavior. This again is a vaccination on site. Vaccinations on site. This is in Yadgir. This picture is at an MGNREGA work site in Yadgir. And this again is a panchayat member who had not taken the vaccine earlier due to a health reason, but thereafter, after it got cleared, she realized the importance of the vaccination and took a vaccine. Apart from modeling good practices, the panchayat also, as you can see, in many places, hesitancy was almost entirely reduced, and people actually queued up for the vaccinations in different places. And in many places, panchayat published the vaccination schedules in advance so that people would know exactly how many doses of which vaccine were available at which centers and between what time to what time. In addition to this, I should say that a large part of gaining the trust of the rural communities has been in the matter of providing relief. This is my final picture, and this is an important aspect of what panchayats in Karnataka have been doing since last March during the pandemic. They've been helping to identify and support those who are destitute, those who are in hardship, whether it requires support in the form of food, in the form of non-COVID emergencies for cases of pregnancy, childbirth, and so on, or emergency medical supplies, transportation, various other things. And this activity has helped Karnataka to gain the trust of rural communities and ensure that all those who are eligible are vaccinated steadily as soon as we can. Thank you so much for the opportunity.
Thank you so much, Ms. Mahadevan, for sharing such insightful on-the-ground stories with us. Indeed, transparent communication in a language and medium that a community can understand helps build people trust in the vaccination program. Our next panelist, Dr. Tanya Sheshadri, is Director, Tribal Health Resource Center at Vivekanand Girijanan Kalyan Kendra, is a medical doctor and community health consultant. Tanya has worked with NGOs and community health centers in southern and northeast India, helping in setting up and managing of community health programs. She has also led public health research projects on social exclusion in health and on maternal health. In BR Hills in southern India, she has helped initiate a participatory action research program to facilitate health-related engagement by the local community. She is an independent consultant with Achyutan Menon Center for Health Science Research and Public Health Division of Sri Chitra Tirunal Institute of Medical Science and Technology. She is also an adjunct faculty at the Institute of Public Health, Bengaluru. Welcome, Dr. Sheshadri. Dr. Sheshadri, since you have worked extensively with tribal communities, please tell us about the issues that tribal people, especially women, face when it comes to the availability and access to COVID-19 vaccines. Are there any difference in challenges faced by Adivasis in urban and rural areas? And beyond vaccines, has COVID-19 unearthed other inequities in Indian healthcare system? Over to you.
Thank you so much, Kunjan. And I'm so glad to be here in front of all of you. And fortunately for me, some of the voices of the people I work with, the Indigenous leaders from the Solita community, you were already able to get a message from them on what they thought are their challenges, their issues, and their openness for vaccination. Now, before I talk about the vaccine equity, I'd like to talk about a story on the second COVID-19 wave in Chamarajanagar district for the tribal people. Now, like in many districts, even in Chamarajanagar, when the second wave came, the district administration, all of us, NGOs, community leaders, everyone, the conversation was hijacked completely by oxygen supply, availability of beds, oxygen beds, ICU beds. With lockdown, there were severe transportation issues. HR shortage, human resource shortages at various primary health centers was suddenly apparent because there was no one to do home monitoring and various other things that were needed. And that's when, while everyone's focus was towards the hospitals and beds, we started seeing these clusters of COVID-19 cases in the rural areas, like what Mr. Mahadevan mentioned. And we also started noticing clusters of COVID-19 cases in tribal hamlets. And in one such hamlet, when such a cluster emerged, what we noticed, we started hearing were reports of people running away into forests, a lot of hostility, a lot of friction with the services, even with Panchayat members and others, which was unexpected. This isn't what we typically see in our district. And in one such conversation in Jirgigadde hamlet where we went, we heard a conversation where the district was struggling at that time. So they had made institutional quarantine mandatory, and people were refusing to be to go and stay in COVID care centers that were far away in unfamiliar areas, and were off. And this was something that the administration was struggling with, because here is a district policy, and here is what everyone else is doing, and then here are a few people who aren't. So there were threats of force, there were threats of police being called. And luckily for us, on one of those visits, one of the Panchayat task force meetings was going to happen. So we had the Jilla Panchayat CEO with us, and he was able to calm everyone down, and everyone sat together in a conversation, which didn't happen very often, including the tribal leaders. And during the conversation, we recognized that the people were not unaware of COVID, or they didn't have any misconception about what COVID-19 is about. But what it was that they did not want to be taken away to a very far area, and they were happy for isolation at a center, provided that it was close to their hamlet. And with that, we established the state's first Adivasi COVID care center in our district, in the state actually. And this was completely supported by the Gram Panchayat. And the Solida Leaders Collective was the one who was managing and monitoring it, of course, with technical advice and support from the local health sub-center and the civil society organizations. Next slide, please. And when we went when the health department went to test people for COVID-19, amongst secondary contacts, you saw 50 to 70 people from a very small hamlet just silently lining up close to the mobile health unit, waiting to be tested, and everyone was shocked. What happened to that conversation of fear and mistrust? And when vaccination campaign opened, this hamlet, more than 90% agreed to be vaccinated. And this, for us, including the district administration, was a lesson that it wasn't just about going and enforcing administrative policy, but it was about having a conversation and gaining trust of the local people there. And when we went around to other hamlets, even in the same panchayat, we recognized very quickly that this was not the case in other areas. Because in other hamlets, they didn't have ASHA workers. They didn't have a good relationship with the local health services. In fact, there were conversations of not having adequate road or water. Drinking water is a huge problem that the local people had been fighting for 20 years. And suddenly today, some of the elders were telling us, after 30 years of struggle, no one came. And so today we have ministers, MLAs, policymakers, doctors, everyone coming to our doorstep saying, here, take this vaccine. This is important to save your life. So, many finding the conversation very ridiculous. And this was a reminder to all of us that the conversation today on vaccine inequity is not merely about just a technology reach or, a solar equipped deep freezer, but it's a conversation about how much we have invested in building relationships with these communities, in addressing the existing socio-political mechanisms that have led to health inequities in these areas. So next slide, please. So the district administration, NGOs, and we have a very strong district Indigenous Peoples Collective at the block level and the hamlet level as well. So all of these came together, and the program we are implementing in the district is a community-led vaccine micro-planning. So it's not the health department that is going around to hamlets and assessing how many people should be vaccinated when or not, but it's the people who are taking the initiative. Of course, they are supported by NGOs and the health workers as well. And the conversations that we have here are what we call culturally safe conversations, where practices, traditional health practices for protection against COVID-19 are also discussed, also, also respected. At the same time, we also talk about vaccination, about the fake news and a lot of the information that has been going around. And they use messages like the social media video that you saw, where they see local people they know, where they see roles that they know, Solidar people themselves on screen who have taken vaccination, talking about their experiences. And it's these kind of conversations that actually help breaking the ice. Next slide, please. We also have conversations at a cluster level, and then at each hamlet level, also these conversations happen. And we also have a local tribal cultural troupe that uses street play and folk songs to God, etc., while weaving in Corona messages and also reminding people about the strength of the collective, the strength of working together, talking together, of not getting misled by other fake news and messages, things that they see in media. Now, one of the few reasons why this strategy is really working well, the way we see it, not necessarily in vaccination coverage, but in conversation, is because the pace of this program is very different. We have moved away from camp-based one-time Jang Bang festival to more let a few people come forward, experience it yourself, look at people around you, and then make up your mind. And one of the messages that the leaders focus out a lot on, including the women leaders, is that just like health is a right, access to vaccination is also a right for each and every tribal person. But the choice for vaccination is an individual choice. There is no force, there is no compulsion, and you need to think for yourself. And strangely, what we find are that women leaders, and in fact, women are coming forward and getting vaccinated much more eagerly than the male leaders. And often the reason for this sometimes we see is also because the ASHA workers, the A&M workers, even the people who come forward to vaccine are also people that they know, that they are familiar with, that they have existing relationships with. But of course, the outcome is very different. Some people want to get vaccinated because they're students and they've been told that in the college, if they don't get vaccinated, they will not be allowed. Some people are coming forward to get vaccinated because they fear, like they see in Bangalore and other places, that tomorrow rations will be denied to them. So that's why they want to get vaccinated today. So the reasons the people are coming forward to get vaccinated are quite different. But what we're very happy with is that the conversation where everyone is free to open up and share their fears. And if they are not happy, they are also able to stand their ground and say, we do not want it yet. We will rethink tomorrow. So with the help of the local health services, we're trying to, we're rolling out vaccination in a way that when the community is ready, when the people are ready, just like in Bangalore, they can ask for the vaccination vehicle to come and they can get vaccinated at the convenience of their hamlet. But some of the lessons that we learn from this, of course, are that the trust in the message is comes largely from the trust in the messenger. And in many places, because we haven't yet invested in relationships with local health services, or there is a mistrust in government, in local governments, that in those areas, the fear for vaccination and the refusal for vaccination is much higher. In fact, we have heard from many of the tribal people that while government schemes have provided relief, have provided water to some, have provided education to some, largely government regulations, the history of relocation from forests, the way they have been treated by government regulations has often caused more fear, more pain and hurt than it has benefited. And therefore, there is a lot of skepticism in any message that the government brings. However, when their local leaders bring those messages, when the local leaders like Madam Mahadevan mentioned, come forward and take the vaccination. The trust in the message is much more. And therefore, this I feel is a reflection of the, the trying to package COVID-19 and its various activities in a, in science, in a sterile package, while not acknowledging the socio-political mechanism for inequities that exist in society. So when I heard the message from, the union government that you pledged today about it being a scientifically driven, technology-driven program, I think the desire for many of us on ground is that it's also a socially planned, it's an equitably planned program, which is led, decentralized, just like Madam Mahadevan said, at the Gram Panchayat level, sometimes perhaps at a more local level than that, and led by the government. But the biggest barrier that we see today, can you go to the next slide, please? Okay. If you could just move to the next slide. I just want to share with you, yes, this is again images from the street play that happens on coronavirus. And if you go to the last slide, I want to show to you, for us, a symbol of hope. The next slide, please. One of the most remotest hamlets today in Chamrajnagar, Alambadi, you see the people who have already taken vaccination. More than 90% of the village has already taken vaccination. And this is one of the remotest villages at the border of Tamil Nadu. This is a very positive sign for us. The people are ready for vaccination. It has taken us less than a month because of the way we have gone about the conversation. But the biggest issue is supply. There is no supply of vaccination, not enough supply of vaccination at the hamlet level. Even PHCs are struggling. There are queues that are very long, and tribal people find it very difficult to navigate these queues because in Karnataka, like in many southern states, they are often a minority in terms of numbers and also in terms of voice at that local level as well. So supply is a huge barrier. And in a previous conversation, there was a mention of quota system for vaccination. And today, even many of us are talking about how perhaps for the Adivasis, perhaps for many such marginalized communities as well, vaccines should be kept aside so that when people are ready, it is available to them. There are stories in Australia and other countries as well about similar issues with Indigenous people and the struggle to reach them. But again, the biggest barrier is supply. But one of the examples that I would just like to share about how equity can come into programs is in Canada, where in British Columbia, for the First Nations people, Indigenous people of that region, recognizing that access to health services and that COVID-19 disproportionately affects racialized and marginalized people like the First Nations, they have been identified as a priority group, and that is where the vaccination program began. So it is possible for equity lens to come into program and to have more socially fair and an equitable outcome. So with that, I'd like to thank all of you.
Thank you, Dr. Sheshadri, for sharing some very, very valid points. I think, for the government to think about having quota or, some major policy decisions is one thing. But I would also like to highlight, through my conversations with people working on the ground, from the state immunization officers to the district immunization officers, ASHA workers, Anganwadi workers, I've learned that, they are also trying at their level very innovative methods, to convince people to take the jab, especially people in the rural areas with tribal communities. I think, there are interventions at that point. Maybe we need more. So, for example, I'll share with you one instance. In a village in Tawang, Arunachal Pradesh, there was a healthcare workers used a picture of the Dalai Lama taking the vaccine to convince people about the safety of vaccine. And I think it worked. I think the immunization team actually were able to vaccinate 97% of the eligible population there. Similarly, in Gujarat, immunization officers engaged the officials of milk cooperatives who enjoyed the trust of local cattle farmers there to convince them about the need for vaccination. But you've rightly said, in many parts of the country, they engaged community leaders and even religious leaders to bust various myths and misconceptions around vaccines and making people comfortable, to come forward and accept the vaccine as such. So with that, we will go to our next panelist, Mr. Venkatesan Chakrapani, who is chairperson of Center for Sexuality and Health Research and Policy. Venkatesan has completed his MD in Madras Medical College and PhD in Postgraduate Institute of Medical Education and Research, Chandigarh. He has been conducting applied and policy-oriented health research among sexual and gender minorities for over 15 years. Dr. Chakrapani, gender minority groups such as transgender, LGBTQ community have always faced discrimination in accessing healthcare. Do you think they face similar challenge when it comes to access to vaccine? And what do you think needs to be done? Dr. Chakrapani.
Good afternoon, everyone. Thank you for having me here. Of course, I have put together my thoughts in the brief presentation, so I will just project that one. 1 second. Okay, so I will focus on mainly the equitable access to COVID vaccines for transgender people, because among the LGBT spectrum people, especially trans feminine people, they are the most visible and the most vulnerable. So I will focus on this particular population. So I think for some of the audience may not know in detail about transgender people. So transgender people are those whose internal sense of gender, the psychological sense of their gender identity, is different from that assigned at birth. So this is actually the definition of WHO. To put it simply, what it means is, for example, if a person is assigned male at birth, after the person grows up, some of those persons may identify themselves as a girl or as a woman. So then that person we call as trans feminine people or transgender women. Similarly, there may be some people who are born as females, and as they grow up, they may identify as a boy or a man. So we call them as trans masculine persons or the man. So my presentation is going to focus primarily on trans feminine people. So in India, there are indigenous trans identities. So many of you are familiar with the terms hijras. In Tamil Nadu, we use the term like Tirunangai, and in other states, different terminologies are used. So many trans feminine people, they face stigma discrimination in various settings, including the family. So because of the discrimination within the family system and in schools as well, many people, they may run away from the family or forced to move out of the families, and that's why many of them, they don't have a good education, or they don't have access to good employment, and that is why they join the Hijra communities, and where the traditional occupations are more of say what they call Mangti, and meaning more of begging and also blessing people and then getting money. And of course, it also for survival sex is also happening. According to the government data, nearly about 50 to 60% of trans feminine people may be engaging in sex work. So trans people, transgender people, especially face multiple stigmas. In relation to trans feminine people, the stigma could be because of their gender minority status, and because they engage in sex work, or they have HIV, or they are suspected to have HIV. So there are multiple stigmas faced by transgender people. So all these pre-existing stressors, they contribute to mental health burden as well. But in addition to those pre-existing stressors, the COVID-19 pandemic has also brought additional stressors. There is a loss of livelihood. There is economic crisis because the occupation or the traditional job of the hijras, or they go door to door to get money from the shopkeepers, or they stand at the traffic signals to get money. So these are then because of the travel related restrictions, so their livelihood was very severely affected, and of course it also contributed to mental health issues. Of course, there are some relief measures from the government. For example, the the National Institute of Social Defense under the Ministry of Social Justice, they gave a one-time payment of like 1,500, and many state governments they are also offering some kind of payments either one time or like at least for a couple of months they are offering, and they are some civil society groups, they are also providing relief services. But if you look at the vaccine coverage, if you look at the available data, the COVID dashboard, they used to actually publish the because under the COVID, in the COVID dashboard, they have people can register as male, female, or other. So other here indicates the transgender people. So under that category, so until recently I could able to see the numbers, but when I looked up yesterday and today, the numbers are not there. So I'm just putting the number which was available in the public domain. So in May, the number was like about 20,000, around 5% of transgender people being vaccinated, maybe at least one dose of vaccine. So you can see the disproportionate. You can see lot of people need to obviously covered by the vaccination efforts. So there are several issues why there are people are actually not reached by this government. So of course there have been many criticisms towards the government that because of the digital divide and only tech savvy people and people who are affluent, people who have smartphones, they can able to get registered in a COVID platform easily and quickly. And obviously, like people who don't have literacy, including digital literacy, they may be excluded because of that. So even though many, maybe I will say like a significant proportion of trans feminine people in cities, they may have access to smartphones. They may not have the digital literacy. They usually use smartphones mainly to send and receive voice messages or video messages because they may not able to, some proportion, a significant proportion may not able to read and write in English or in local languages. So that was one major barrier. And another major barrier is about the lack of government issued identity cards. So many people may not have the Aadhaar card or the voter ID in the gender identity they prefer. So they may have it in the sex assigned at birth identity card, but they may not have the identity card in the preferred or self-affirmed gender identity. That's another problem. And some activists, they have pointed out that they don't like the term others in the registration. It says, like, why can't they put, for example, as simply as a transgender person? So rather than putting as male, female, and others, why not like say transgender persons? Some people even wanted to have this as trans feminine persons and trans masculine persons, so that there can be some distinction be made among the transgender umbrella. Of course, a paid vaccination or not, it's not affordable to many people, many HOs. Yeah. Because another issue is in relation to the medical mistrust. So many trans feminine people, they have had bad experiences when they went to the government public health system. And so they also may be naturally afraid to go to the vaccination centers which are located in government hospitals or in government centers. So they may be afraid of discrimination by the healthcare providers or even by the public who are coming to the vaccination centers. Actually, such incidents have been reported in newspaper articles. The misconceptions and vaccine hesitancy among trans feminine people have also been reported. Because some trans feminine people, they are also on hormonal therapy, like feminizing hormones. So there are concerns about interactions with the hormone therapy, whether the vaccine will have any negative effects because I'm on hormone therapy, like that they may think. And some people, they also have expressed fears in relation to post-vaccination complications. For example, in Tamil Nadu, one famous celebrity died on the next day after having COVID vaccine. So people thought that because of the COVID vaccine, that person died. So you can see so misconceptions are not only among the trans feminine people, but even among the general public. And according to the government data, about at least 3 to 9% of trans feminine people, they are likely to be having HIV infection. So the HIV positive trans people, they get concerns about like getting vaccinated. Of course, there are several government initiatives, but maybe very broadly, maybe, but not maybe scaled up. These are more of yes, maybe for the directives issued by the government of the guidelines. The other initiatives, like say setting up trans-specific vaccination campaigns, camps, or having mobile vaccine booths, or having specific vaccination drives for transgender people, specifically in collaboration with civil society agencies. These are more of, let's say, one-time activities or ad hoc activities. So they are not actually sufficient to reach an adequate number of transgender people, as reflected by the 5% figure we saw. Of course, for example, some government institutions, like say the Delhi administration, they have set up some transgender specific vaccination centers. And of course, from the civil society, both from the community-based organizations who work with transgender people, and also from the general non-governmental organization, there have been vaccination drives in collaboration with government and private stakeholders. And transgender people, they have also been involved in creating awareness about vaccination through social media and door-to-door campaign, not only for trans people, but also for the general public. And in the June-July Pride Month celebration, that also provided an opportunity to discuss about COVID pandemic-related distress and also the need to get vaccinated. And recently, the circular that vaccination brings no negative health outcomes for HIV positive people. Of course, any HIV positive people, not just trans people who are HIV positive. These are just photos to show like some special vaccination campaigns, camps for transgender communities in different cities here. In this case, like Coimbatore and in Thane. And this is again, vaccination drive for the LGBT community as a whole in Mumbai, organized by Namsafa. And again, just to show that in the LGBT Pride Month, there are discussions about COVID pandemic and vaccination as well. So these are some ideas like which I can elaborate in the subsequent discussions. So what can be done to ensure equity in access for transgender people? So one is, of course, addressing the vaccine hesitancy through trans community driven awareness campaigns and having trans community ambassadors. And of course, ensuring enrollment even outside the CoWIN platform, for example, allowing walk-ins and accepting NGO issued letters or identity cards. And of course, the field interactions, people also talked about like getting need to have some reimbursement mechanism to compensate for travel cost for transgender people. And even if they can able to take paid vaccination because of lack of availability in the public sector, then the need for getting reimbursement for that paid vaccination doses. And there is National AIDS Control Organization HIV prevention projects, which are currently reaching out to nearly like 47,000 trans feminine people. So even if the vaccination can be, say, done through these what NACO calls the targeted intervention programs for trans people, I think we can able to reach a lot of people, because the 5% figure shows like about 20,000 people, but we have potential to reach more through this government program, because there are already trans feminine people are registered. Of course, there's a need to ensure non-discrimination in vaccination centers. We have to sensitize the center staff and also the public who are coming there. And of course, we need to scale up trans-specific mobile camps and vaccination centers. Yeah, I think with that I will stop. Yeah, thank you.
Thank you so much, Dr. Chakrapani, for sharing your experiences and views and raising some really very pertinent issues. You have raised one issue regarding AEFI, the fear of suffering an adverse effect or getting a side effect, severe side effect post-vaccination is a major issue. Dr. Kang, I would like to understand from you, how can we communicate what is required to make people feel safe while going, while taking vaccine, and also how to communicate, to make them know like where to go, where to get help if that happens.
I think you've raised a tremendously important issue when communicating about vaccines, and it significantly influences the trust that people place in the system that gives them the vaccines. So one is the communication about the potential adverse events prior to the vaccination. And the second part is what happens if it does happen to you.
Yeah.
And that question of trust being built before you get the vaccine requires that you communicate the chances of rare side effects and common side effects with people prior to the vaccination. A lot of people worry about allergies, a lot of people worry about thrombosis with thrombocytopenia syndrome. They've all heard about blood clotting. But I think the kind of communication that we have tends to be quite cursory, and it is something that requires attention to detail. And one way of doing that is to arm providers with the correct information, as well as training in how to communicate things. For example, the fact that having a clot following an AstraZeneca vaccine is less likely to happen than having a lifetime risk of a road traffic accident. But that kind of communication is not usually used. The second part which you raised, which I think is very important, has been addressed in principle. On the CoWIN app, you are supposed to be able to report safety events. But many safety events happen and people wind up in hospital and then struggle to report either to the vaccine company or the person who provided them the vaccination. For them to understand that there is a remote reporting system can be quite challenging. So I think if the goal is to ensure equity by building trust, communication around AEFIs is absolutely critical. And as scientists, we can look at mechanisms, we can provide approaches, but it's ultimately down to implementation. And some places and some people and some organizations do it better than others.
I think another very important issue that you touched upon during your talk was the infertility issue. In certain states, especially Punjab, women were really scared of becoming infertile, fertility, reproductive health issues after taking vaccines. And you said it's a very scientific fact that we need to convey. How to simplify these scientific facts so that people on ground can understand them and accept it?
I think we have a misconception that science cannot be communicated, and that people who belong to certain levels of society are incapable of understanding the principles by which we make recommendations or act. And quite frankly, I don't think that's true. I think everything that we communicate in science is largely about common sense and distilling down to principles, communicating those principles. Everybody understands prevention. Everybody understands the harms that certain actions can have. So I think something like this issue of infertility and how you communicate that, to me, is the fact that the vaccine contains a part of the virus. If you were going to be infertile because you got the vaccine, don't you think you would also be infertile when you got the infection? It is the same part of the virus. So it's not that hard to communicate. You just have to think about what's the principle that you're trying to convey and put it in language that people understand.
Yeah. True, very well said, Dr. Kank. One another issue that we've highlighted during our conversations is the lack of access to digital technology. Can that be a hindrance for elderly people, people in rural and remote areas? Ms. Mahadevan, I would like to understand from you, what do you think can local administration do to overcome this digital divide?
Yes, so as I said, in our panchayats, we already have the computers, we have connectivity, we have trained staff who are working on the computers. Much of our work happens on a digital platform, and therefore it's not a difficult thing to take a laptop, take a printer, and go to a village in order to enroll people or to help them to register on the site. We had a very detailed training, set of trainings, actually 3 trainings on vaccination for Gram Panchayat task forces, where one of the things we said was that even in case of helping people to register, since the portal allows you to register 4 people with 1 phone number, if there are persons who don't have access to a phone and need that help, then the panchayat needs to help them with registering on the portal using the same person's phone number that's used for the first dose, so that they can keep track of how they register. So it's certainly an issue, but it's not an insurmountable issue. It's possible to help people at the village level by either taking a computer to the site or by bringing people to the panchayat and helping them to enroll. There are enough people who are both functionaries who are there and volunteers, because we've had a lot of volunteers, young people working with panchayats in order to help people to enroll, to get updates, even to print out vaccination certificates. We have had help at the panchayat level. So it's both doable and it's something that should be done.
Yes, a very interesting experience I would like to share with our panelists. I think in Himachal Pradesh, in some of the hilly terrains, what immunization officers also did was they used ballot boxes in the villages, and the villagers who were willing to take the vaccine, they were, dropping their names and other details in the ballot boxes, and then those ballot boxes were brought to the vaccination center, and then they were entering the details on the CoWIN portal. So that was also very interesting. Just wanted to add. Another challenge that we talked about is vaccinating homeless people and those without ID cards. How can we ensure, Dr. Chakrapani has touched upon this issue, that, how can we do that? But if we talk about the entire country, how can we ensure that they are not left out? Dr. Tanya or Dr. Chakrapani, if you could like to address to this issue.
Yeah. Okay. So with regard to the transgender people, especially trans feminine people, there are in some states they have the transgender welfare board, and they also issue identity cards. So apart from the list of identity cards which can be used for registration in the CoWIN, if there is some flexibility in allowing, say, if they come with a letter of an NGO or a community agency, so whether that can be used, so that so it's basically what we want to assure by registration using a particular identity card is whether the person is a valid person and the same person is getting vaccinated both times. So if that can be assured through some other mechanisms, so I think that kind of flexibility should be there. So I have seen detailed guidelines of how to go about it. Like government has released some guidelines, but of course there's a lot of there's some paperwork involved in that. It's like it's another sort of obstacle. Of course, allowing the walk-ins. So one problem with that is even people who are registered, they are not getting the slots. So just saying that okay, we allow walk-ins, people can walk in at any time. That is not going to be helpful, because that should be some way by which we have to ensure that people walk in, but they will also be having getting the vaccine. So of course, I have seen a couple of newspaper articles in which some government officials, they have openly talked about the vaccine shortage, because it's not very comfortable to talk about vaccine shortage, right? So I think people can easily Google and then find some of the government official talking about it. So it is not that people are there and it is only because of the vaccine hesitancy people are not going. Of course, there is some proportion of vaccine hesitancy, but a lot of people, they also want to get vaccinated because they are worried about their livelihood. Even among the transgender people, they want to have this because about the livelihood issues, and they have seen deaths among the family members. Of course, everyone I think is affected in one or another way. We know of people who have died or suffered from COVID. Yeah, I think so. That's what I thought. Like maybe just to make it the flexibility should be there. So that's the main idea. Yeah.
Dr. Tanya, would you like to add your comments to it?
Yes. One of the things I just want to talk about as we talk about digital divide and reaching out to particular people, like Dr. Kang said, there has been a routine immunization program. ASHA workers, ANMs, we've been talking about vaccination in Indian villages, even with tribal people, for many decades now. And it is those conversations that are actually, and the existing mechanism that is actually, I feel, more contributing to the success today of the COVID-19 vaccination program than new technology or trying to today in a month address the digital divide between rural India and even within rural India, from its remote parts to its suburban parts. The question I feel, just to maybe provoke the conversation a bit, could also be about, did we really need a new technology to come in and to monitor AFI or to look at whether people are getting the vaccine or not, when we already have mechanisms? For polio vaccine also, for other vaccines also, AFI are being tracked. We have a rotaviral vaccine that has recently come in. We have pentavalent vaccines. All these vaccines deserve that and have received as a lot of focus in the past decade as well. And rather than strengthening the existing vaccination program for better quality data, reporting, and monitoring by bringing in a new technology and then saying that, oh, because people are not adept to that technology, hence they are not able to access health services, is a constructed mechanism, is a constructed structure which is inducing further inequities. Rather, if we had focused, for instance, when we talk about homeless or transgender people, and I would say even for tribal people, on already trying to take health services to them, then perhaps this vaccination issue wouldn't be an issue. And so my fear is trying to bring in mechanisms today which are solely focused on COVID-19 vaccination may be a band-aid, may be firefighting the crisis in which we are today. But we may, once COVID-19 vaccination coverage improves, we may forget this. And we may again tomorrow, in the next wave of COVID-19, be having the same conversation in the family. So, not really the answer to your question, but I just wanted to make those comments.
Okay, that's one point of view, definitely. Okay, we'll move on to one more very important issue when it comes to our children. there has been a lot of debate about whether we need to vaccinate children on priority. Dr. Kang would like to know your views on the subject. Dr. Kang, do we have you?
Yes, I'm sorry, I was on mute. So I think ultimately we are going to vaccinate children because I think it's inconceivable to us that we could vaccinate and protect adults against disease when we don't protect our children. But all the data that we've seen so far in terms of prioritization and equity does not bring children to the top of the priority list, unlike many other infectious diseases. This is one where we really need to get vulnerable adults vaccinated first, then follow that with children with comorbidities, and then finally come to all children. So I think it's going to be a while before we get children vaccinated. I know that the government has made announcements about starting childhood vaccination as early as August, but I think we've got our priorities all wrong. We really need to make sure that we reach vulnerable adults first, cover them, and then begin to think about children.
Okay. There are many questions from audience I can see, but before we move to audience questions, I would like to play a video of Dr. Alka. We've just received it. Dr. Alka Sharma from DBT. She has a message for us, for the audience. Can we have the video, please? Can we play the video? Okay, I think there is some technical issue that we're facing there. In the meantime, I'll...
Good afternoon, everyone. It is my pleasure to be a part of this session. Improving vaccine equity in India is a very important topic during current pandemic. As you all know, currently 3 vaccines, that is Covaxin, Covishield and Sputnik, have got emergency use authorization. The Department of Biotechnology and its PSU, Biotech, has proactively responded to the pandemic and supported a large number of projects for development of COVID-19 vaccine candidates. Some of the vaccine candidates are at advanced stages of clinical studies, include DNA vaccine by Zydus Cadila, mRNA vaccine by Genova, protein subunit vaccine by Biological E, and intranasal vaccine by Bharat Biotech. A rapid regulatory framework has also been developed in consultation with all the stakeholders to expedite the processes for approvals. The Department of Biotechnology has played a very important role to create and strengthen the ecosystem across the country. This includes establishment of 54 clinical trial sites across the country, immunoassay laboratories at THSTI Faridabad, Isha Pune, and Syngene Bangalore. Facilities have also been created for animal challenge studies. Very recently, 2 facilities, vaccine testing facilities, have been established in the country, that is at Pune and Hyderabad. Mission COVID Suraksha has been launched to expedite the process for development and manufacturing of vaccine. Under this mission, we are facilitating capacity enhancement of public sector manufacturers to scale up vaccine production. Though efforts are being made for development and manufacturing of vaccine equity is an interdependent exercise. Different arms of the government, vaccine manufacturers, and also NGOs need to work in harmony. So in conclusion, I would like to say that efforts are being made in an integrated way for optimization of vaccine production and also ensuring no disruption in the vaccine supply chain, which is the need of the hour. Thank you.
We have very little time left with us. In fact, we are over time. But I would like to take some audience questions. Dr. Khan, one of our audience is asking, could you please give us examples of when vaccine design and manufacture needs to be tailored to a specific population?
Zoster vaccines for the adult, well, for the elderly really, where you need to increase the dose of antigen that is in the vaccine to be able to protect against zoster is one example of that. There are others as well, but that's the one that is most commonly used. You can change the adjuvant amount. There are lots of ways of playing with vaccines, especially tailoring them for populations that require extra protection or can't respond to a particular vaccine. So for example, if you have allergic reactions to one vaccine, you might want to switch to a different one, which is why having a basket of vaccines is better than a single one.
There is one more for you. In terms of increase in positivity rate, Northeast is moving towards more than 10% every day, especially in Mizoram and Manipur. What is your advice to the government so that positivity rate can be decreased?
Yeah. So test positivity rate is not a number to be looked at in isolation. I know that in the absence of a lot of granular data, a lot of people focus on test positivity. WHO recommends keeping it below 5%. But it's important to recognize that a test positivity rate is something that you should do something about. What's happened actually is that, as with many other numbers that are set as goals for the Indian public health program, we tend to see a lot of gaming. So, for example, if my test positivity rate is going up, all I have to do is go across town and test in a neighborhood where there aren't a lot of cases, my test positivity rate will come down. Instead of treating it in that fashion, we have to recognize that a rising test positivity counts only if nothing has changed in terms of the testing. The only ways that you want to handle test positivity is to expand testing, but expand testing and do something about it. The testing just to report numbers is no use. You have to track cases, you have to make sure that there is isolation, because the goal of test positivity rates is to try and prevent transmission, try and be prepared for what is likely to come in the future. A high test positivity today means that I will have admissions next week or the week after, and I need to be ready for them. So what should Eastern Indian states do? Strengthen their health system, strengthen their ability to respond to acute problems.
Okay. Dr. Tanya, there is one for you. How to get the practice of trust building and community health to continue beyond pandemic?
Well, I think that's a 60, 70-year-old conversation. And there are many lessons to learn from clusters throughout. One way, I think Madam Mahadevan has showed us, the Department of Panchayat, the way the Panchayat department in Karnataka decentralized, listened to each Gram Panchayat task force, allowed them to make decisions, innovations, appreciated those innovations, supported them all the way up to the state level. I think that was a fantastic way of not only building trust and relationships, but also boosting morale, and recognizing that from a centralized solution or a way is not going to work. And that led to more gains, I think, in the long term, the way the Panchayat and community now talk to each other or communicate to each other, perhaps in areas where this was an issue earlier. Leadership being led by community, I think that is a fantastic mechanism. And that is something that I hope that, even the health department can, though we do through the National Health Mission, decentralization is one of our core principles, but I think that kind of listening to people on the ground, appreciation and support from the system would definitely be one way. Another way that we, of course, we have learned and we follow in Chamarajanagar is collective action. Have all the actors, including the ones that you are trying so hard to protect, unlike in a charity model, make everyone sit on the table and listen to voices. I think inclusivity, diversity, and listening, I think those are definitely ways of maybe not solving or making changes in coverage rate in the immediate short term, but it will definitely go a long way in building trust and sustaining whatever efforts we are making today in the coming years.
One of our audience want to know the experiences in how you approach risk communication related to vaccines, such as common side effects, etc., to group with low literacy. Ms. Mahadevan, would you like to address this question?
Yes. So as I mentioned, we had prepared a lot of extensive IEC material in different formats, in text as well as audiovisual. So we were very conscious that not only groups with low literacy, but we still have elected representatives in the panchayats who sometimes require audiovisual means of communication, and so that was very much uppermost in our mind. We produced material which was very highly visual. Again, as Dr. Khan said, we did not have to dilute any messages. The message was very strong. The message was conveyed in a very clear and simple manner, but it was not diluted. It was converted. We had we're very fortunate that we had both agencies, as well as we had a lot of very committed communication professionals who were volunteering with us on our team, who helped us to convert it into different languages, dialects, and different forms of communication, audiovisual, jingles, songs, and so on. And of course, along with that, as I showed you, there was one of the slides, a lot of house-to-house communication. I think we're very fortunate in India to have this frontline force of ASHA workers and Anganwadi workers who already have the trust of the communities. And with them, local elected representatives moving with them only made the message go stronger and go from house to house, actually ensuring that the message was not only communicated but also customized depending on whether the issue was in that particular house was of pregnancy or of doubts pertaining to taking the vaccine during pregnancy. Then there's one kind of message, and if it's about fears about whether or not, concern, not fears, but concerns about whether or not persons can continue to consume alcohol. That was one of the concerns that came up. So the message also was customized because people were going, teams were going from house to house to carry out the communication strategy.
Yeah. Thank you, Ms. Mahadevan. I think we've covered most of the questions, and there are many more with us, but paucity of time, I would like to conclude, with your views during our discussion today, such as that the right planning, transparent, science-based communication, and a clear policy framework that ensures adequate production and equitable distribution are key to achieving universal immunization. Inoculation of the entire eligible population is the only way to defeat SARS-CoV-2, the virus that has caused unprecedented suffering. It may be challenging, but certainly not an impossible task. Thank you everyone on behalf of India Alliance and India COVID SOS. I thank all our panelists and participants for sharing many solutions that can make big difference on the ground. Thank you very, very much.
Thank you.
Thank you.